Thanks for joining us. This is a program that will focus on the uh, epidemiology, awareness, risk stratification, treatment of MASLD, both in terms of lifestyle modification, but also new drugs. I'm delighted to be, I'm Zobair Younossi. I'm the chairman of the Global NASH Council, and delighted to be with a number of my colleagues who are renowned experts in the field of MASLD and MASH. What we will do is to start with my presentation on epidemiology, and then we'll go on to awareness and risk stratification through guidelines that are developed and algorithms. We'll then move on to the discussion about lifestyle modification by Professor Shira Zobair, and then we will have a presentation by Professor Laurent Castera on medical treatment. We will have a bit of a time for the journal to also present what they're doing, and then we'll move on to question and answers. So with that, let me just remind you about what MASLD is and what its global and global burden of this disease. So MASLD is the now make sure that I'm sharing. So MASLD was actually is a part of a spectrum of steatotic liver disease that was defined a few years ago through a consensus between different societies. That means basically AASLD, EASL, as well as the ALA and a number of other societies that came together to change the terminology that used to be describing this disease, NAFLD or non-alcoholic fatty liver disease, to steatotic liver disease and connect this to metabolic dysfunction that actually underlies the pathogenesis of this disease. So the terminology changed to MASLD. Now also, in the spectrum of steatotic liver disease, we have alcohol-associated liver disease, and a new term, which is MASLD, that combines some component of moderate amount of alcohol use as well as having risk factor for steatotic liver disease or metabolic diseases. Now, the reality is that when you look at the right side of the slide, that there is a great deal of overlap between MASLD, MASLD, and ALD. And the current thinking is that instead of actually thinking about these as sort of buckets or different sort of groups, that there's a great deal of overlap, and folks can go from one part of the spectrum to another part of the spectrum, depending on how much alcohol they drink and how well their metabolic sort of risks are controlled. When you look at the global burden of MASLD, the top part of the panel of this slide, the global prevalence of MASLD is about 38% when you look at the most recent studies. This is from meta-analysis we published a couple of years ago. When you look at those individuals that have type 2 diabetes, about 70% of them, this is again from a different meta-analysis, about 70% of them have MASLD. Now, the prevalence is very high in certain regions of the world, specifically Latin America and also Middle East and North Africa. But if you look at the rest of the world, the prevalence is very high in every part of the world. And of course, this has to do with the dual epidemic of obesity and type 2 diabetes. The pediatric prevalence of MASLD is about 10 to 15%. And when you look at differences in terms of age, you'll see that the prevalence goes up with age, so that in young individuals, the prevalence can be as high as 30%, especially in boys. So it's higher in boys and it increases with age. When you look at what causes the progression of this disease, now, of course, out of the patients with steatotic liver disease, only a small proportion of these patients can progress. So looking at MASLD, only those patients that have steatohepatitis, so evidence of liver cell damage, are the ones that can progress. And even 10 to 15% or 15 to 20% of these patients can progress. Now, there are a number of things that can contribute to this pathogenesis that, of course, includes visceral obesity with white adipose tissue, which is a endocrine organ that produces a lot of adipokines and cytokines, as well as other abnormalities, including gut dysbiosis or microbiome abnormalities, oxidative stress. All of these leads to ultimately to the activation of the stellate cells and production of collagen, which leads to fibrosis. Now, as you can see in the bottom, as I mentioned, when you have other components that actually either contributes to this progress, such as some amount of alcohol, for example, binge drinking for a period of time, that progression can actually be faster. Or if you actually improve metabolic abnormality, you reduce your weight for a period of time, or improve type 2 diabetes, or actually stop alcohol consumption, then there may be a regression of fibrosis. And this actually led to large clinical trials showing a pretty high placebo rate that could be as high as 20%. Now, when you look at the prevalence of the spectrum of steatotic liver disease, and this is from the most recent NHANES database. The NHANES is basically a data set from the United States that look at general population. And steatotic liver disease was described as having a CAP score of 280 or higher. You see that the prevalence of MASLD is about 33%. That of MetALD was 1.86%, and ALD is 1.16%. If you look at the bottom, if you look at cirrhosis, especially in MASLD, which is about 2.85% development of cirrhosis, and then ALD about 10.37%, you see that there is a discrepancy that we see. There is a lot of cirrhosis and advanced liver disease related to alcohol-associated liver disease, but actually the prevalence is lower. And this may be related to our inability to actually get more accurate history of alcohol. So if you do PET testing, which is a test to determine alcohol consumption, then you see that the prevalence could be changed for about 20% of patients that were diagnosed as MASLD to ALD or MetALD. In terms of mortality, again, from NHANES data, you'll see that MASLD is associated with high rate of mortality compared to controls, but MetALD is higher, it's associated with higher mortality, and ALD is even higher. So there is a gradation of mortality risk as you go from MASLD to MetALD and ALD. In terms of causes of death in patients with MASLD, you see that despite the fact that there is actually an increased number of liver-related mortality, there is also a preponderance of cardiovascular mortality in these patients. So cardiovascular remain the number one cause of death among patients with MASLD, but in those that have more advanced fibrosis, then liver becomes the most common cause of death. So this is an important concept to recognize. And of course, this data has been now confirmed in the global burden of disease, where you see that there's actually, when you look at 4 different diseases, MASLD, ALD, hepatitis C, and hepatitis B, and look at liver cancer deaths and cirrhosis death, you see that in most regions of the world, the mortality from, say, hepatitis B-related cirrhosis death is actually going down. They're all, this is annual percent change. So you see that the mortality is actually in green, meaning that we're making gains against hepatitis B. In contrast, when you look at MASLD, there is a lot of red suggesting that mortality from MASLD is increasing. Another line of evidence that supports sort of more progressive liver disease and higher higher burden of this disease has to do with liver transplantation in the United States as well as Europe. This is actually recent data that's been just recently analyzed and presented. You'll see that the number one indication for liver transplantation is alcohol, followed by non-alcoholic fatty liver disease, or what's now called MASLD. Hepatitis C, which used to be a much more common cause of mortality, is now actually declined substantially over the past few years. Another important issue here is that there is actually a group of patients that will have lean MASLD, and these are the patients that are much more common in places like North or South Korea or part of Asia. The prevalence could be as high as 25%. So one of the other issue that I wanted to actually bring up is that this disease is not a single disease, or you can look at this only as liver disease. They're associated with a number of other metabolic diseases, including chronic kidney disease, cardiovascular disease, as I mentioned, and also a number of malignancies. And looking at the cardiac disease and metabolic sort of associated steatotic liver disease, you'll see that the prevalence of MASLD in the group patients with coronary artery disease is higher. And when you look at mortality of patients that have the combination of the two is also higher. Malignancy has also been shown to be higher in these groups, especially gastro-GI malignancies. This is actually from Alina Allen from Mayo Clinic, showing that patients with NAFLD or MASLD have higher malignancy related to MASLD, which is regardless of obesity. This is actually even if you control for obesity. Chronic kidney disease is also quite high, especially when you look at stage 1, 2, and 3A kidney disease, and it's again associated when you have NAFLD or MASLD in the context of chronic liver disease. It's actually associated with higher mortality. And finally, sarcopenia is more common in patients with MASLD and associated with higher rate of fibrosis as well as higher rate of mortality. In addition to the clinical outcomes, economic outcome of MASLD is quite substantial. This is actually a Markov model that's been recently presented, showing that when you look at the burden of disease here, we're talking about liver-related deaths, as well as costs associated with this disease, direct healthcare costs with this disease in 9 different countries. There's substantial increase in both clinical outcome as well as direct healthcare costs. Now, humanistic burden of MASLD is really related to quality of life and fatigue. It's also very common. About 40% of patients will have fatigue, which is substantial. And fatigue not only impairs quality of life of these patients, but also it is associated with mortality among these patients. So what are some of the drivers of this disease? There are a number of important drivers. You can look at those as genetic risks, PNPLA3 being an important one. Some of the clinical risks, for example, if you have more than one risk factor for metabolic abnormalities, I'll show, and also some socioeconomic sort of risk that can impact this, and as well as environmental risks such as use of refined food and alcohol, as I mentioned. So the more component of metabolic syndrome you have, the higher the rate of mortality. And this has been shown in a couple of different studies that I'm actually showing you here. And again, PNPLA3 has been associated with more advanced liver disease, both in terms of fibrosis, but also in terms of actually steatohepatitis. And there is a geographic distribution of PNPLA3. There are other SNPs that also has been associated with high risk, but it's not been confirmed in every population, every study at the moment. And finally, when you look at socioeconomic sort of factors, food insecurity, when you look at food swamps and food deserts, there's actually an association with MASLD and MASLD mortality. And in fact, when you look at these issues in food environment globally, it's associated in high economic sort of countries, socioeconomic countries, is associated with increased rate of prevalence of MASLD, and lower socioeconomic sort of countries. It's actually the opposite, because poverty and lack of food is associated with MASLD at that point. So the take-home message is that MASH and its associated complications are growing globally. Clinical burden, mortality, economic burden, and quality of life burden, humanistic burden of MASH are substantial and increasing. This burden is driven by non-modifiable factors such as genetic factors, but also some that are modifiable, ultra-processed food, etc. And at this point, I think one of the most important things that we can do is to raise awareness about the disease, do risk stratification with an IT, and then try to actually implement lifestyle modification and provide drugs for those who actually can be candidates for the treatment. So I'll stop here, stop sharing my slides, and I'm going to turn the podium to Professor Vincent Wong, who's going to talk about